My third presentation is a slipped capital femoral epiphysis, which is the displacement of the proximal femoral epiphysis. It is also known as femoral capital epiphysiolysis. This pathology is confined to children going through the pubertal growth spurt. Usually boys are affected more than girls, and they are a little bit older. The boys usually are between 14 and 16 years old, and the girls are on average 2 to 3 years younger. Left hip is affected more commonly than the right hip, and if one side slips, there is 25 to 40% risk of other side also slipping. The slip of the capital femoral epiphysis occurs through the hypertrophic zone of the cartilaginous growth plate, as we shall see in the next slide. And the patients are either fat and sexually immature or excessively tall and thin. There are many predisposing factors, especially hormonal imbalance, as underlying cause of physical disruption. Normally, pituitary hormones, as we see here, pituitary hormone activity, which stimulates rapid growth and increased physical hypertrophy during puberty, is balanced by increasing gonadal hormone activity, which promote physical maturation and epiphyseal fusion. The disparity between these two processes may result in the phases being unable to resist the shearing stresses imposed by the increase of body weight. This occurs most obviously in the hypogonadal child or in a juvenile hypothyroidism. We have also other mechanical factors, as the pericondial ring, which becomes relatively thin in this age group and provide less support for the increased load transmitted through the phases during the growth spurt. And most patients with slipped capital femoral epiphysis have a greater than average body mass index. Adolescents, which are affected by slipped capital femoral epiphysis, have also either relative or absolute femoral neck retroversion, with the phases has an increased obliquity. For sure, trauma plays an important role, as an acute slip 30% or progressive displacement as an acute on chronic slip. In slipped epiphysis, as we have said, it happens usually it occurs usually through a hypertrophic zone of the cartilaginous growth plate. And this slide is very important for you. And the femoral neck is displayed forward while the epiphysis remains seated in the acetabulum like this. And the epiphysis slip posteriorly on the femoral neck. If the slip is severe, the anterior retinacular vessels are torn. At the back of the femoral neck, as we see here in this bar, the periosteum is lifted from the bone with the vessels intact. These vessels may be the main or the only source of blood supply to the femoral head, and damage to these vessels by either manipulation or operation may result in avascular necrosis of the femoral head. Physical disruption leads to premature fusion of the epiphysis. This is usually accompanied by permanent external rotation deformity and apparent coxavara. Clinically, the patient usually is a child around puberty, typically overweight or very tall and thin. The presenting symptoms is pain, sometimes in the groin, but this is an important idea. It may be only in the thigh or the knee, which can be very misleading. It soon disappears only to recur with further exercises. Limp also occur early and is more constant. This is the cause of limping child at age of 14 to 16 years old. This is a very important idea for you. Sometimes the child becomes aware that the leg is turning out. When he walks, there's out-towing. On examination, the leg is externally rotated and there's some about 1 to 2 centimeters shortness. Characteristically, there is a limitation of flexion, abduction, and medial rotation. The classic sign is the tendency to increase external rotation as the hip is flexed. And following an acute slip, the hip is irritable and all movements are accompanied by pain. After clinical examination, we should do radiological examination. We depend usually on X-ray study. X-ray usually in the first stages or at the beginning of the lesion or the disease, usually X-rays are normal, and the changes may be extremely subtle. They are not obvious at the first stages. In the anterior posterior view, if we draw a line along the superior line here, if we draw a line along the superior surface of the femoral neck, normally it should intersect the epiphesis in this part. In the early sleep, the epiphesis may be flush with or even below this line, and this is called the 3-to-1 sign. And again, the metaphyseal blanch sign of Steele in this part is a double density seen at the level of the metaphysis on the anterior posterior X-ray. It reflects the posterior cortical lip of the epiphysis as it's beginning to slip posteriorly and becomes superimposed by the metaphysis with decreased epiphyseal height. So the epiphysis, when it turns, it shows us the base of the epiphysis, and the height of the epiphysis becomes decreases. We can see like this decrease of epiphyseal height, and there is physeal widening in comparison to the normal sides. The lateral X-ray view is the most important view, and the femoral epiphysis in this view is tilted backward. This is most reliable X-ray sign, and minor abnormalities can be detected by measuring the angle subtended by the epiphyseal base and the femoral neck, as we see here. This is normally a right angle, and any angle less than 87 degrees means that the epiphysis is tilted posteriorly. Slip capital femoral epiphysis can be graded by clinical presentation and or radiographic appearance. Radiological appearance or grading is based on measurement of the magnitude of the slip relative to the width of the femoral neck. This can be divided to mild, moderate, and severe displacement. The mild displacement is less than 1/3 of the width of the femoral neck. Moderate is between 1/3 and half. Severe is greater than half of the femoral neck width. The simplest classification is based on the timing of onset. It can be pre-slip, and the child complains of groin or knee pain, particularly on exertion, and there may be limp. Examination is often normal, but may demonstrate reduced internal rotation. The X-ray usually show widening or irregularity of the phases. In acute sleep, symptoms present for less than 3 weeks. Painful hip movements with an external rotation deformity, shortening, and marked limitation of rotation. The greater the limitation of motion, the greater the degree of sleep, and symptoms last for less than 3 months. In chronic sleep, usually the pain in the groin, thigh, or knee, lasting more than 3 weeks. Episodes of deterioration and remission, loss of internal rotation, abduction, and flexion of the hip, and limb shortening. With acute on chronic sleep, long prodromal history, and an acute severe exacerbation. The aim of the treatment is to preserve the epiphyseal blood supply, which is very important, and as we have said, the main blood supply lies on the posterior wall of the femoral neck, and to stabilize the physis and to correct any residual deformity. Manipulative reduction of the slip carries a high risk of avascular necrosis and should be avoided. The choice of implant depends on the degree of slip. In minor slip, the deformity is minimal and needs no correction, and the position is accepted and the physis is stabilized by inserting 1 or 2 screws or threaded pins along the femoral neck and into the epiphysis under fluoroscopic control for sure. In moderate slip and severe slips, this is unacceptable slip and causes marked deformity, which, if untreated, will predispose to secondary osteoarthritis. So, open reduction may give good results. We must know that the complications of the slip capital femoral epiphysis are numerous, and most of them is related to the way of treatment, especially the surgical treatment and the manipulation. The most important complication is the slipping at the opposite side, opposite hip, which may happen between 20 to 45% of cases. So we should always check the normal asymptomatic hip periodically to note if there will be signs of abnormality of the epiphysis and the growth plate. We may do surgical stabilization opposite side to prevent this from happening. Avascular necrosis of the epiphysis, this may be iatrogenic and is minimized by avoiding forceful manipulation and operation which may damage the posterior retinacular vessels. Articular chondrolysis also, or the cartilage necrosis, which probably results from vascular damage, which is often iatrogenic, and it does not appear to be related to the method of treatment. In some cases, the condition improves spontaneously, while in others it leads to loss of mobility and of the hip and the osteoarthritis. The last complication is coxa vara, the slipped epiphysis that goes unnoticed or it is inadequately treated may result in coxa vara. Thank you.